For pancreatic cancer, the only curative treatment is surgical removal of the tumour. For cancers of the head of the pancreas, the operation used is usually a pancreaticoduodenectomy, or a removal of the pancreas head and duodenum. Although named pancreaticoduodenectomy, in practice it actually involves removing the pylorus of the stomach, as well as the gallbladder and common bile duct, as these structures are in close proximity to the pancreas head and hence are susceptible to local spread, via a common artery, the gastroduodenal artery. Although there has been recent development in laparoscopic pancreaticoduodenectomies, they are predominantly done via an open approach. The incision is commonly a rooftop incision, with retractors used to further open the abdominal cavity.
Once the incision has been made, the first step of the operation is visualization and exploration, specifically looking for any signs of metastatic disease.
This can often be tricky, as the majority of structures that we need access to are retroperitoneal. Two well-known maneuvers can be used to help access these structures. The first is the Cattell-Brask maneuver. To do this, the hepatic flexure of the colon is mobilized and reflected to the left to reveal the pancreas and duodenum. Here, the first few important structures can also be seen, such as components of the biliary tree, the duodenum and jejunum. In order to properly see the structures surrounding the duodenum and head of the pancreas, we need to get behind them. As they are both retroperitoneal organs, an incision must be made through the peritoneum overlying the duodenum, allowing it to be reflected over to the left. This step is known as cockerization or Cocker's incision. After this, important vessels that need ligation are revealed, such as the cystic artery and gastroduodenal artery. The superior mesenteric vein can also be seen here, running posteriorly to the pancreatic neck and encased by its uncinate process. The next general step is dissection of the gallbladder and biliary tree along with vessel ligation. First, the gallbladder is slowly dissected away from the gallbladder bed. The cystic artery is then identified, ligated, and divided, followed by division of the common hepatic duct. The gastroduodenal artery is then ligated and divided, disrupting the blood supply to the head of the pancreas, which is to be removed. Further dissection then occurs around the neck of the pancreas, particularly with separation from the superior mesenteric vein. The next few steps involve division of specific organs. The next division made is the stomach, which in a classic whipples is done proximal to the pylorus. Alternatively, the division can be made distal to the pylorus if the tumour is not as extensive. This is known as a pylorus-preserving pancreaticoduodenectomy, or PPPD. Where possible, this should be first line, as various studies have shown it improves long-term outcomes for the patient. However, for the remainder of this video, we will be covering a classic whipples operation. So following this, as all the feeding vessels have been ligated,
The pancreas can be divided at its neck.
here the colon has been removed from the illustration for visibility. The fourth division carried out is at the junction of the duodenum and jejunum. So far, we have divided the common hepatic duct, the stomach, the pancreas, and the duodenum. As all appropriate vessels have already been ligated and or dissected, the fourth division enables us to remove the specimen entirely. Once the specimen has been removed, the reconstruction can begin. The cut end of the jejunum is brought superiorly towards the cut end of the pancreas. A small incision is made on its side and a small plastic tube is placed into both the pancreatic duct and the jejunal lumen in order to ensure patency. The duct and the rest of the pancreas are then stitched to the side of the jejunum, forming the pancreatico-jejunal anastomosis, also known as a pancreatico-jejunostomy. It is important to note that the next steps of construction can differ between HPB centres. Here, the jejunum is actually divided again, more distally, with a stapler. As it can get quite complicated, for the purpose of this video, we'll mark each end of the cut jejunum with an orange line in order to keep track of where they end up. The distal end of the jejunum is then pulled superiorly towards the cut end of the stomach. Incisions are made and the two of them are stitched together to form the gastrojejunal anastomoses, also known as a gastrojejunostomy. Just distal to this anastomosis, another small incision is made, and the common hepatic duct is stitched to the side of the jejunum, forming a hepatico-jejunostomy. Finally, the proximal end of the cut jejunum is incised and joined to the distal jejunum in an end-to-side anastomosis, forming a jejuno-jejunostomy. The finished product includes 4 anastomoses: the pancreatico-jejunostomy, the gastro-jejunostomy, the hepatico-jejunostomy, and the jejuno-jejunostomy. The food eaten can pass through the stomach and into the jejunum, where it mixes with bile secretions. Further down the jejunum, secretions from the pancreas can mix with digestive matter. Below this point, the GI tract remains normally intact, so digestion can continue as normal. As previously mentioned, reconstruction can differ between centres, with some centres not making the second division of the jejunum further down. Here, after creating the pancreatico-jejunal anastomoses, the stomach can be pulled down and the same bit of jejunum can be stitched to the stomach and the common hepatic duct. This final product only has 3 anastomoses: the pancreatico-jejunostomy, the gastro-jejunostomy, and the hepatico-jejunostomy. Although this construction may be simpler, the former is often done to make surgical intervention easier if there is a post-operative pancreatic anastomotic leak. As the pancreas is anastomosed to a different section of jejunum, this way the anastomotic leak can be dealt with surgically without having to disrupt the gastro-jejunostomy or the hepatico-jejunostomy.
Upon closure, all of these patients will have drains inserted. As well as being able to detect hemorrhage, these drains enable you to detect the amylase concentration of any fluid being secreted from the operation site inside the abdomen. This is important as a high amylase concentration may indicate an anastomotic leak at the pancreatico-jejunostomy.
Complications associated with the whipples procedure can be split into early complications and late complications. Early complications include bleeding, infection, delayed gastric emptying, and anastomotic leaks. With regards to bleeding, perioperative coagulation optimization and adequate intraoperative hemostasis decrease the risk of bleeding and blood loss. Addressing infection, the use of perioperative IV antibiotics and sterile techniques dramatically decreases the likelihood of infection. Another serious form of major abdominal surgery is anastomotic leaks. In the whipples shown, there are 4 anastomoses from which leaks could occur: the pancreatico-jejunostomy, the gastro-jejunostomy, the hepatico-jejunostomy, or the jejuno-jejunostomy. Typically, symptoms of anastomotic leaks include fever, abdominal pain and peritonism, and tachycardia. For the PJ specifically, octreotide is often used prophylactically post-op.
Later complications include diabetes due to pancreatic insufficiency and weight loss due to impaired digestion. To prevent this, all patients who undergo a Whipples procedure will be put on Creon, an artificial version of pancreatic enzymes. This in turn aids digestion.
Following the procedure, the patient will have regular tests to assess for continued operative success and screen for recurrence. These include blood tests to monitor pancreatic cancer markers such as CA19-9 and CT scans, initially done at 3 to 6 monthly intervals for the first 2 years, then annually thereafter. The prognosis for pancreatic cancer is typically poor, with 5-year survival being less than 5% overall. 85% of patients present with advanced disease and hence are inoperable. For those that do not have an operation, there is a 66 to 92% chance of later recurrence.
Those that undergo resection and tolerate chemo have a 5-year survival rate of 30%.
In this video on pancreaticoduodenectomies, we have covered the common steps, including incision, visualization, ligation, division, and reconstruction with anastomoses. Variations to the procedure, such as pylorus preserving pancreaticoduodenectomies versus the classic whipples, and different forms of reconstruction. The early complications, such as bleeding, infection, delayed gastric emptying, impaired digestion, and anastomotic leak. And the later complications, including weight loss and diabetes. Finally, we covered follow-up and mortality, including bloods and scans, prognosis, and recurrence.